Hello everyone, this is Tom, a member of the patient support team here at optimail.co.uk, and today I'm joined with Alistair, the co-founder and co-director of Optimail, to discuss the relationship between TRT and cardiovascular disease. We start by discussing the myth that testosterone replacement therapy increases the risk of cardiovascular disease, which predominantly originates from the bodybuilding circle. We then move on to discuss some actual potential cardiovascular risks on TRT, like elevated hematocrit. And finally, we finish off by discussing some of the mechanisms through which testosterone replacement may actually confer cardioprotection. As always, please do not interpret anything that is discussed in today's episode as direct medical advice or instruction, as neither myself nor Alistair are medical doctors, and we are simply discussing the underlying physiology of TRT in a manner in which is meant for solely entertainment purposes. So, without further ado, let's get straight into the episode.
So today we're asking the question, does TRT, or testosterone replacement therapy, increase the risk of heart attack or stroke?
Yeah, so if you look at the scientific literature on the topic, the idea seems to stem from the observation that because men die younger and more often from cardiovascular disease compared to women, it must be testosterone or androgens, because that is one of the primary differences between male and female physiology. However, this has never actually been elucidated, and there's now an abundance of evidence demonstrating that not only does TRT not cause heart disease, but deficiency of testosterone, and by proxy estradiol, is associated with increased risk of heart disease in men. If you think about this logically, what time of a man's life is he most at risk of developing heart disease? When he's older, 60s, 70s, 80s? Generally speaking, that is the time when a man's testosterone and also estradiol levels start to decline. And the same paradox also exists for prostate cancer and male pattern baldness and a lot of other diseases that are claimed to be caused by androgens, when in reality their prevalence is highest when androgens and estrogens are at their lowest.
I guess as the argument kind of opposing that would be, okay, but you've had 50, 40, 60 years of a build-up of your androgens having an effect over that time. You know, the classic one that's always kind of mentioned is prostate cancer. And they say, well, if you look at certain populations who have higher testosterone levels, higher androgen levels, they also tend to have higher rates of prostate cancer.
The issue with data of that sort is, generally speaking, it's association. It's not demonstrate causation. And I think if you want to prove causation, you have to do an RCT where you give men testosterone and see what happens. And for both prostate cancer and heart disease, at least, there's quite clear evidence that neither of those two issues are the rates of those two conditions do not increase when you give men exogenous testosterone. And this was highlighted by a recent meta-analysis that was published, I think it was towards the back end of August, and it was titled Testosterone Replacement Therapy in Hypergonadal Men and Myocardial Infarction Risk, Systemic Review and Meta-Analysis. And this pulled data from 8 different studies with over 55,000 hypergonadal men. And I think what was most interesting is that there wasn't a standardized treatment intervention. These men were on injections, they were on pellets, they were on gels. And as most people who are informed on this area will know, gels and pellets, generally speaking, aren't the best intervention for testosterone replacement therapy. And even with this considered, there was no statistical significance between the group that received testosterone replacement and the group that received nothing with regards to the risk of myocardial infarction, which, for those who aren't aware, is a heart attack. It's the medical name for heart attack.
Yeah, I mean, it's pretty interesting. It's like you were saying, it's interesting that there's obviously a number of different protocols included in this systematic review. There were probably a couple of studies that were using gels, a couple that were using injections, a few using patches, a few using a combination of them. And they all found overall that there's not really an association between the two.
Yeah, I think that's important to highlight, just because a lot of people, if they're on pellets or even with injections, the protocol that the patient will be on is likely to be rather ineffective with regards to the dose used and injection frequency. So even with that in mind, there was still no increased risk of heart disease with men on, one of the studies had men on 250 milligram of enanthate injected every 2 weeks, which is going to produce a huge spike in testosterone shortly after the injection, a huge spike in estrogen, and then it's going to slowly drop off so that they're potentially lower than they were before treatment, before their next injection was due. But again, even on a poor protocol like that, there was still no increased risk of a heart attack, which
and we would associate that kind of protocol with increasing hematocrit and hemoglobin, which is the main thing, wrongly or rightly, that is associated with increased risk of clots when you are on TRT. I say wrongly or rightly, and we'll get onto that later on in this video, but it is quite an interesting meta-analysis. And I think there's another thing to be said here, which is that there was another recent study, it's probably not that recent any longer, but it was basically saying that total mortality over the length of the study was higher in men who had low testosterone than it was in the men who had been put on TRT and had their testosterone levels increased, despite them in that study finding a slightly higher risk of some cardiovascular events in the first year, I think it was, for certain men.
Yeah, and I think it's going to depend on what the study defined as a cardiovascular event, because I can't remember the exact name of the paper now, but there was a paper that got released a few years back that claimed that men who took testosterone were at a significantly greater risk of developing cardiovascular events compared to men who don't use testosterone. But they actually considered elevated hematocrit to be a cardiovascular event to the same severity, or it was counted the same as a cardiovascular event like a myocardial infarction or cardiomyopathy or things like that, where realistically elevated hematocrit, although it could potentially pose a risk for blood clotting and issues like that, it's nowhere near, the severity is nowhere near to that of the other two issues mentioned, and it can also be managed very easily with bloodletting or protocol adjustments and things like that. So yeah, I think again it's going to come down to the methodology of the study used.
I mean, it seems to be quite an individual response from what I've seen in patients. Some patients, they'll be on not particularly raised testosterone levels, maybe 20 nanomoles per liter, quite average, and their hematocrit levels can increase substantially when they start treatment. They just seem to produce a lot more red blood cells than the average person in response to the testosterone levels. Whereas some people come back with a much higher testosterone level and they have no indication that they're going to have a hematocrit level over 0.5. It does seem to be very individual.
It's because the mechanism of testosterone-induced erythrocytosis isn't particularly clear. There's some evidence to support that testosterone administration increases erythropoietin production, which is a hormone produced by the kidneys, which travels to the bone marrow to stimulate red blood cell production. There's also some evidence that testosterone and also estradiol can suppress the production of a protein called hepcidin. And this is a protein that sits in the middle of a channel called ferroportin that's in your enterochromaffin cells in your gut. And the function of ferroportin is to take up iron from the gut when you eat any sort of iron-containing food like meat or reinforced cereals and things like that. Hepcidin sits in there to inhibit the uptake of iron. So when you suppress the production of hepcidin, you're going to get a significantly increased uptake of iron from your foods. But I think hepcidin is regulated by, although testosterone and estradiol do heavily suppress it, it's also regulated by multiple different hormones and other vitamins and minerals. So I think, and also I assume genetics play a large role too. So there's going to be a large inter-individual variation with regards to that particular pathway, which could account for the differences in erythrocytosis in men who everything else on paper with regards to their total testosterone level and general protocol is roughly the same.
I mean, that's definitely what we see. So
yeah, and I think obviously that is one of the main issues with regards to cardiovascular risk of testosterone. And that for those who don't know, hematocrit is the ratio between the plasma and the red blood cells of your blood. So essentially, it indicates how thick or how viscous your blood is, and if your overall red blood cell count goes up without increasing the absolute amount of plasma, that will increase your hematocrit because your blood is getting thicker, and there is some evidence to suggest that this does pose a risk for increased risk of blood clots and things like that. And this is generally speaking what we would consider to be the major cardiovascular risk factor for men on TRT, and it is it's always measured on follow-up blood tests, and it's relatively easy to fix in the vast majority of men through blood donations or reducing their testosterone dose if it's too high.
Yeah, so I mean, while we're talking about erythrocytosis, we were going to basically discuss the difference between erythrocytosis and polycythemia.
Polycythemia vera is a blood disorder in which every single type of blood cell, including white blood cells, in addition to red blood cells, are produced in excess. So not only do you get an elevated hematocrit, a thicker, more viscous blood due to the increased amount of red blood cells, you also get an increased production in white blood cells that are involved in clotting, like platelets. And essentially this disease, because you're getting the combination of the more viscous blood and an overproduction of the white blood cells that control clotting, your risks of having a blood clot and cardiac infarction or ischemia in the brain and things like that, your risk is increased considerably. The problem is, in men on testosterone replacement therapy, it's only the red blood cells that are produced in excess. It's not the white blood cells or the platelets that largely control clotting. And a lot of evidence from papers investigating the negative effects of polycythemia vera are extrapolated across to men on TRT to claim that an elevated hematocrit is going to cause blood clotting, when in reality, there still isn't enough evidence to say whether or not testosterone-induced erythrocytosis poses the same cardiovascular risk as a condition like polycythemia vera, which is where the vast majority of evidence comes from.
Yeah, and I mean, it's the same kind of mechanism that increases red blood cell count in, for example, men at altitude, well, men and women at altitude. For example, living at the base camp of Everest, you're going to have a pretty high hematocrit. That doesn't, as far as I'm aware, that doesn't extrapolate over to increasing your risk of clotting disorders, such as, you know, having a myocardial infarction or a pulmonary embolism or DVT or something like that. So, yeah, the problem we have here with a medical treatment and how we monitor it and how we treat potential side effects is that all of the guidelines, all of the endocrinology guidelines, BSSM, etc., basically say the same thing. If your hematocrit is above 0.54 before you start treatment, you shouldn't start treatment. It should be lower. If whilst you're on treatment, if your hematocrit goes above 0.54, then you should stop treatment and reduce it through bloodletting or just ceasing the actual medication for a bit. So obviously there's two sides to this. Firstly, we can't take the risk with people's say, oh, well, it might be okay because there's potentially some theoretical evidence that such and such, that polycythemia vera doesn't apply the same way as erythrocytosis in terms of risk of clotting. We could assume that, and we would be putting people at risk potentially. So unfortunately, we have to go with all of the guidelines which state that if it goes above 0.54, we need to do this, that, and the other to reduce it.
Yeah, I mean, one of the main pillars of medicine is first do no harm. And if there isn't clear evidence that we've proven that erythrocytosis in men on TRT is entirely different and does not pose the same risk to the individual that polycythemia vera or other similar blood disorders would, then there's no reason to take that risk when you do have access to bloodletting or other interventions that can lower it. And again, if you've got someone running a HCT of 0.57, 0.58, that's getting to a point where their blood is getting rather thick. And
the other thing is it may be increasing your blood pressure, and increase in blood pressure is also linked to increase in cardiovascular events. So a number of reasons why we can't.
Yeah, I think
go with this.
One of the other main concerns with regards to cardiovascular risk in men on testosterone replacement therapy is that when you look at studies that use, and these are largely mechanistic or rodent studies, there aren't too many in human males, but in studies that use 500, 600, 700 milligrams per week of testosterone, which is much, much, much more than we ever use for TRT, you can have a upregulation of the sympathetic nervous system, which produces an increase in the circulating level of catecholamines, which are a class of hormones that adrenaline and noradrenaline belong to, and they can increase the force at which the heart contracts and the rate at which the heart contracts, while simultaneously producing vasoconstriction in certain blood vessels throughout the body. And this can essentially lead to chronically elevated blood pressure and things like left ventricular hypertrophy or just generalized cardiomyopathy or cardiac remodeling. Again, this is not really specific for men on TRT because it is mechanistic data and it is from using very, very high doses, but it is also a risk that is rightly or wrongly associated with testosterone replacement therapy, although there isn't any actual evidence, again, demonstrating that testosterone replacement causes these issues.
It's another good reason for not just, I read on the forum that I can have 250 milligrams a week. You're going to take 250 milligrams per week for life, then you are running a risk of potentially having some of these other issues.
I completely agree with your point. The only distinction would probably be it depends on what level that 250 milligram is put in the person at, because 250 milligram for the vast majority of people will have them running well into the 80, 90, 100 nanomole per liter, which for those who aren't in the UK, 2,000 nanogram per deciliter plus. And there's no long-term evidence to support whether or not that's safe, be it for cardiovascular health or any other type of pathology that you might associate with testosterone use. So yeah, I think I completely agree. The risks are there. Are they going to happen on a well-managed TRT protocol? There isn't any evidence to support that that's the case. And as we mentioned before, there's an abundance of evidence demonstrating that low testosterone that is uncorrected is associated with an increased risk of cardiovascular disease, and there's quite a few mechanisms there that could be contributing.
Yeah, so I mean, in terms of benefits, because we spoke about this before, does seem to reduce overall mortality in men versus the control group who have low testosterone still and aren't given TRT. And, there are a few potential mechanisms by which that happens.
Yeah, one of the main ones that not too many people are aware of is that androgens in general are very potent glucocorticoid receptor antagonists. The glucocorticoid receptor is the receptor through which cortisol, the primary steroid of the sympathetic nervous system, exerts its action through. And when cortisol binds to the glucocorticoid receptor, it breaks down lean tissue like skeletal muscle, but also organs. The thymus is particularly susceptible to breakdown from cortisol. It does that to break down the protein in those tissues into their individual amino acids to then enter into circulation, travel to the liver, and be converted into glucose via gluconeogenesis in times of stress to be used as immediate fuel source, with the view that as soon as you have overcome this stress, partly through the increased amount of glucose in the blood that's helped you do that, the cortisol can then come back down and your tissues can be rebuilt. The problem is when testosterone levels are low, because it's a potent antagonist of that receptor, you can essentially have unopposed cortisol chronically. So your lean tissues are constantly being broken down. And like any other muscle, the heart is also susceptible to this. It is more protected than something like skeletal muscle because it has a very high concentration of androgen receptors and a very low concentration of glucocorticoid receptors, so that when you are in a stressful event and your body produces an excess of cortisol, it doesn't immediately break down your heart muscle, because that would be very counterintuitive to survival. Yeah. But when you're in a situation where you have very hypergonadal levels of testosterone, and generally speaking, most of the data we have suggests that cortisol levels do tend to increase as people age, that's when you can start to get the breakdown of the heart muscle and heart failure that's commonly seen in older men. So when you correct testosterone deficiency, you are protecting the heart because, one, you're antagonizing the glucocorticoid receptors, but you're also restoring activity at the androgen receptor, which can help the heart and lean muscle in general rebuild.
Yeah, I mean, this is why being chronically stressed your whole life is not a good thing. And also why testosterone is protective, kind of, I guess, antagonistic to stress in a way, because it antagonizes cortisol as well. You become more stress resistant, become more resilient.
Exactly.
And that's, particularly if you're anxious, that can be a really important thing as well.
That's one of the mechanisms through which testosterone can help with anxiety and how low testosterone can cause anxiety, which is a very common presentation in men with hypergonadism, is that they've essentially lost on the physiological level their ability to resist stress. And then even a minor stress is something that realistically shouldn't evoke a response from you. You can often feel overwhelmed and like you're unable to deal with that when normal, healthy people can.
I mean, I used to have a lot of anxiety before starting TRT. And then it was honestly, after about 2 days, I noticed I'm almost disappeared. It was completely crazy. And I was like, wow, this is exactly what I needed. Yeah. And at times when I had high estrogen, it came back. As soon as I control my estrogen again, now I rarely get anxious about anything. And I wouldn't call it, it's not anxiety then. It's just, responding to a certain stimulus that might be a bit like, you might have a negative stress response, which is kind of normal.
Yeah, exactly. I think
so you can't really call it anxiety anymore.
Yeah, some people do, not referring to you here, but some people can, if anything goes wrong when they're on TRT, they attribute it to something wrong with their protocol or because they view testosterone as a panacea to health, and you can still have anxiety and issues like that.
Sure.
If you're in an environment or a general situation that even in a healthy person would evoke that. But it does help enormously with people who really, really struggle with that stress resilience in situations where realistically it should not be evoking a response.
Yeah, exactly.
Yeah.
I mean, so the other thing, if we're talking about health, we're talking about cardiovascular health in particular. One of the other key ways that testosterone can be beneficial is obviously if you have low testosterone, you, as a man, you convert testosterone into estrogen, so you have less estrogen. And we know that estrogen is so important for your health. Improves your endothelial health and which can improve your kind of blood flow, and it can improve your lipid profiles as well.
Yeah, both of those are really important. Estrogen, I think everyone knows about the vasodilative effects of the signaling molecule nitric oxide just because of how popular and prevalent drugs like Cialis and Viagra are, which they increase the downstream messenger through which nitric oxide exerts its action, and you can get improved vasodilation, which can manifest as improved erections, which are mediated via vasodilation of veins in the penis. But also, people will just report reduced blood pressure or just generally better blood flow, especially on daily tadalafil. And estradiol actually regulates the expression of an enzyme called endothelial nitric oxide synthase that actually produces nitric oxide within the endothelium of your blood vessels. So again, if you're deficient in estradiol, you can literally have a deficiency of vascular nitric oxide, which is what mediates the vasodilation behind erections and just general blood flow. So again, if you imagine that puts you in a chronic state of vasoconstriction, but your blood volume is still the same, it leads to increased pressure. So again, you can develop high blood pressure and also unpleasant issues like erectile dysfunction very easily just through a deficiency of testosterone, which leads to the downstream deficiency in estrogen. And then, obviously the positive effects of estrogen on HDL is clear, and most people know the benefits of HDL. It's the lipoprotein that's associated with removing cholesterol that's been deposited into arteries and taking it to the liver to be metabolized, whereas LDL is what's associated with it's the lipoprotein associated with deposition of cholesterol into arteries that underlies
plaque formation.
Yeah, exactly. And I think there's a lot more research going into this area, and the idea that HDL is good and LDL is bad is seems to be a little bit reductionist, and the issue does seem to be more nuanced. But the benefits of HDL are still quite clear, with the people that have higher levels of HDL are generally more protected against cardiovascular disease, and estrogen does increase HDL.
Yeah, I mean, this is probably one of many reasons why women tend to live longer, but it's probably one of the main reasons why TRT also could potentially increase your lifespan and reduce mortality, particularly when you're on a good protocol and you're not reducing your estrogen levels. Interestingly, we've just started talking to a company that do glycan age testing, which is basically a way of looking at your biological age compared to your actual age. So one of the key things and they've done a lot of research into it to support the fact that this is actually accurate and effective testing, but also that certain treatments and lifestyle changes can improve your biological age. And one of the main ones from a doctor in America who's very into not only life extension, but hormone therapy in men and women. He looked at the impact of hormone replacement therapy in women, replacing estrogen in particular, on these patients' biological age through glycan age testing. And the improvements in their glycan age from 6 months of having estrogen replacement therapy was, some of them 20 years improvement, reduction in biological age. They also did another test in men, test study in men where they used an AI, and I spoke to them about it and asked them what dose they're using. They're using 1 milligram of anastrozole a day.
Wow.
Not sure I would have wanted to be on that study. But anyway, they showed that by doing that, even though they're on TRT, these men's biological age increased. So negative impact from increasing, completely wiping out estrogen, this was.
It's not surprising when you look at the rates of cardiovascular disease in women. Up until menopause, they're generally protected. It's extremely rare that a woman will die of any sort of cardiac or vascular issue before menopause. And as soon as they lose their ovarian estrogen and also progesterone production, their rate of generalized heart disease is increased significantly, and also
and osteoporosis and all the rest of it.
And this is also an effect that's seen in premenopausal women with breast cancer when they're given very, very high doses of aromatase inhibitors to remove estrogen from their body because they're trying to treat the estrogen positive breast cancer, which obviously comes first because obviously having osteoporosis and increased risk of heart disease isn't nice, but if you're going to die within the next couple of years from breast cancer without treatment, then it's a cost-benefit analysis there. But the increased risk of cardiovascular events in women premenopausal is again increased significantly when you remove estrogen from the body with pharmaceutical interventions.
It's so interesting how all of these things impact different areas of health, but the fact that hormones are often ignored in a lot of these situations is very interesting, isn't it? For example, working in the NHS and seeing women with osteoporosis, postmenopausal, very frail, very kyphotic, because they've got loads of wedge fractures in the thoracic where they're just, they end up like this, bent over, right over, proper widow's hump or whatever they call it. And, it would all be about calcium and vitamin D, but also I think it's biphosphorate. I can't remember the name of the medication that they use as well. It's basically to try and improve bone density. When I imagine if they actually gave them estrogen, it would probably improve it a lot more. But you would expect that it would have probably a strong effect, or at least in conjunction with those medications. Why not give them that? I think there's so much fear around increasing the risk of breast cancer in women from giving them HRT that it's just not even considered.
It's quite strange too that oftentimes, you're right, it's just not even on the table, and if people don't have the appropriate information, they don't even know that it's a viable option. But if they are one of the lucky ones who, with the doctor who understands the area, oftentimes if they follow the guidelines, they then get put on synthetic estrogens and progestogens, which don't appropriately or adequately replicate the endogenous functions of estradiol and progesterone. They're synthetic molecules. It would be the equivalent of taking a man who is extremely hypergonadal and putting him on stanozol or misterolone as a monotherapy, which those two drugs can have their purpose and they can fulfill a role in different medical conditions, but they're not a replacement for testosterone if a man is completely deficient. And it's the same for women with these synthetic estrogens and progestogens, which generally speaking increase the risk of cancers and other unpleasant conditions more than the endogenous hormone that they're supposedly superior than and they're supposed to be replacing.
That's interesting. I didn't realize that. I mean, that's probably why bioidentical estrogens are becoming quite popular now for women. I don't know if that's the same as the kind of pharmaceutical options given, or if they are actually more, maybe that's why they're called bioidentical, that they're actually identical to the female estrogens.
There's a lot of stigma that's being pushed by the pharmaceutical industry and medicine in general against the term bioidentical hormones, because that term generally refers to those that are made by a compounding pharmacy. And for some reason, whether it's just the pharmaceutical industry not happy that people are making very cheap and effective products and giving them to people, I don't know. But there's quite a lot of lobbying against using compounded hormonal replacements versus pre-made pharmaceutical products at the moment. And the NHS and the NICE guidelines are moving more towards saying body identical versus bioidentical, because it's making the distinction between bioidentical compounded hormones coming in creams and things like that versus body identical but still pharmaceutical manufactured by an actual company like Merck or Pfizer or something like that.
It's probably a topic for another time, but
yeah.
But anyway, great to speak to you, Tom, and thanks for that information. And we'll speak to you guys soon.
Sounds good.
Cheers.
So, we hope that you enjoyed this discussion on the relationship between TRT and cardiovascular disease. But before we go, just to clarify a few things that we touched upon so that nobody gets the wrong idea. We are absolutely not saying that elevated hematocrit on TRT isn't an issue, nor that you should let it run as high as possible without concern. We were simply discussing the alternative view of testosterone-induced erythrocytosis, a view that largely stems from the work of Dr. Neil Rouzier and Scott Howell PhD. If you'd like more information on this, I would highly recommend watching Scott Howell's video lectures on the topic. As always, if you have any questions about anything touched upon in today's episode, you're more than welcome to leave a comment below or get in touch with us at info@optimail.co.uk, and we'll be more than happy to get back to you. Thank you for watching and listening.